Okay, guys, really quick here, we're just going to pick up where we left off from earlier this morning and talk about temperature and temperature regulation. Um, we have to talk about temperature regulation when we talk about sort of the involuntary control that our nervous system has on our bodies. Um, and that being said, if we were in class, I would ask, what portion of the central nervous system is the primary mediator of thermal regulation? And the answer to that is hypothalamus. So I want you to remember that. And temperature regulation really does vary in response to a lot of different factors. Location, activity, environment, someone's circadian rhythm, and gender, and sort of the hormones that, that gender carries with it. And interestingly, body heat itself is produced by a chemical reaction of metabolism and skeletal muscle tone and skeletal muscle contraction. So that is where we get our body heat. That is why we are, 98.6 degrees Fahrenheit. Temperature regulation is also sort of controlled by thermoreceptors, sort of keep us in check. And those are found both peripherally and centrally. Peripheral thermoreceptors are in the skin, and central thermoreceptors are found, again, in the hypothalamus, also in the spinal cord, and some of the abdominal organs, and they provide the hypothalamus with the information. So those other structures centrally located provide the hypothalamus with the information. But again, hugely, hugely controlled by the hypothalamus. So again, as I mentioned, body heat production, is, or chemical thermogenesis, as we call it, is the combination of chemical reactions of our metabolism and skeletal muscle contraction. So that being said, when our body wants to hold on to heat and conserve heat, let's say because it senses that the body temperature is too low or too cool, there are a lot of different mechanisms that our body does to sort of conserve that heat. That's things like increased muscle tone. So that's literally why we shiver or why our teeth chatter when we're cold, because it's trying to increase that skeletal muscle tone and create more muscle contraction, therefore more heat production. Our body will vasoconstrict. The reason for that is especially peripheral vasoconstriction. Centrally warmed blood is shunted away from the periphery to the core where the heat can actually be retained. So it's much more helpful for the heat to be in the core versus out in the periphery. Again, that's why our fingers feel so cold, our toes feel so cold in a cold environment, because the warmed blood is being shunted away from the periphery and into our core. And obviously that sort of mechanism of the blood being shunted away from the periphery is an involuntary muscle or involuntary sort of mechanism. But that being said, there are certainly voluntary mechanisms as well that we do to try to conserve heat. And some of those voluntary mechanisms would be like obviously just bundling up when we feel cold, getting under a warm blanket, putting on your coat, moving around, stomping your feet at a cold football game when your toes are so cold, you're just sort of like constantly moving your feet inside your shoes. Curl up in a ball, sort of in a fetal position. The reason that curling up in a ball, or, assuming the fetal position when you're cold, is something that just kind of inherently comes to us is because it actually decreases our surface area. So it actually helps us warm up in that way. So anyway, that's sort of the discussion between heat production versus heat conservation and the difference of those two. Heat loss is another topic, and you can see all the different ways that our body can actually lose heat. The hypothalamus actually responds to a warmer core and peripheral temperatures by reversing the same mechanisms resulting in heat loss. So some of those things that we do in the previous slide to conserve heat, we'd obviously do the opposite of to try to get off some excess heat. Actually, in your text, there's a table on page 331 that discusses kind of each one of these different mechanisms of heat loss. You don't necessarily have to, know them like the back of your hand. I just wanted to mention that. And as always, like I try to do, I do try to talk a little bit about whatever topic that we're discussing and talk about it a little bit on the age spectrum. Temperature regulation in the pediatric population is very important because pediatrics actually produce sufficient body heat, but they're really unable to conserve the heat that they produce. And some of the reasons for that is that because of their small body size and high body surface to weight ratio, they also have a very sort of thin subcutaneous layer. So, what might be some considerations of care that we need to think of with pediatrics, and specifically I can think of in terms of considerations of care for infants, even newborns. That's why, we put hats on newborns, why we swaddle them, why we're really careful with bathing newborns, and making sure that we don't keep them sort of exposed for prolonged periods of time to water or just to the ambient air around them, because they really are unable to conserve any heat produced, and they have a really hard time sort of thermoregulating in those environments. So that's why we keep them warm, we keep them swaddled, we keep their hats on, and we really don't sort of submerge them into bath water or, like I said, expose them to a lot of water early on in their lives because of that. And then on the other end of the spectrum, we have the aged population. So in aging, you actually see slow blood circulation and vasoconstrictive responses and decreased metabolic rates. Well, given the fact of all the things we talked about already in terms of thermoregulation, those things happening should sort of make sense in why they have issues with temperature regulation. They also have decreased sweating, decreased shivering, and truly a decreased perception of heat and cold. So they're not as sort of sensitive to it. So let's say they're out in the cold on a snow day sort of thing. They're not going to maybe feel as cold or perceive that they're as cold as we are, and therefore expose themselves for longer periods of time to a cold environment that could certainly be detrimental. So just sort of those things to think about in terms of the elderly spectrum. Okay. So that's kind of a general sort of background and basis for temperature regulation. Now for the rest of the time here, we're just going to sort of briefly talk about temperature on the high end, so fever and hyperthermia, and then temperature will end up talking about temperature on the low end, so hypothermia. So fever, to start off with, let's talk about the sort of the patho of fever, so to speak. Fever is the resetting of the hypothalamic thermostat to a higher level in response to endogenous or exogenous pyrogens. So by exogenous pyrogens, I mean something from the external environment. So some sort of endotoxin, maybe from a pathogen, so to speak, that stimulates the release of endogenous pyrogens from phagocytic cells inside our body, which raises the set point. Okay, so let's take a step back here for a second and talk about what that means. Let's talk about the patho of fever. So what essentially happens in fever is that because of some sort of pyrogen, some sort of bacteria, let's say, usually we get pretty high fevers with bacteria, so we'll use the example of bacteria. Some sort of toxic substance has been released from a bacteria, which actually resets our hypothalamic thermostat. So we know normally that our normal body temperature is around 98.6, right? So what happens in a fever situation is that the hypothalamus gets this thermostat reset to, let's say, 103 degrees Fahrenheit. So your body's thermostat now is sitting at 103, but yet your actual body temperature hasn't reached 103 yet. How do you feel? When you first sort of notice that you have a fever, how do you feel? You feel cold, you feel chilled, you feel achy. All you want to do is, get under a blanket and lay there for 4 days. Like just climb into bed with 5 blankets on you, 4 layers of clothes, and lay there and not move. It's such an awful sort of cold, chilled feeling. And the reason for that is your hypothalamus has reset its thermostat to 103, and you're way down here at what's usually normal at 98.6, and your body's saying, what the heck, what are you doing way down there? No wonder you feel cold. You're supposed to be at 103. And that's why you feel so cold when you first initially get that fever. So then let's say either you take an antipyretic, you take Tylenol, which sort of quote unquote breaks your fever, or, over several, days or an extended time period, the pyrogens have sort of run their course, so to speak. But either way, no matter what the reason is, when a fever comes down, what then happens is the hypothalamic thermostat gets reset again, back to 98.6, back to your normal temperature. Well, it resets its thermostat back down to 98.6, but you're still up at 103. So then when your fever quote unquote breaks, how do you feel? You feel so hot. You end up kicking off all those layers of blankets that you had on you. You wake up in the middle of the night and you're dripping with sweat. You feel like you're, so much sweat that you could like wring your bed sheets out. You're kicking off the covers. You're stripping off layers of clothes. Um, and you feel so incredibly flushed and hot. And that's because the thermostat has been reset now back to 98.6, but you're still way up at 103. No wonder you feel so hot, right? So that's kind of the patho of fever and how you feel, what you feel when you have fever, is because of this resetting of the hypothalamic thermostat. Um, So that's sort of the patho, if you will. Now, you can also have another type of fever called fever of unknown origin, or FUO. This is when the body temperature is above 101 Fahrenheit and don't really know why. So remains undiagnosed. So as to what this issue could be. It remains undiagnosed after either 3 days of hospitalization and sort of investigation and attempt to diagnose while in the hospital, or, not even in a hospital setting, but you've gone for 2 or more outpatient visits, and the fever cannot still be explained. And there's a lot of different reasons for why a fever of unknown origin may occur. It could certainly be a pyrogenic sort of infectious process. It could be an inflammatory process, neoplastic, so meaning some sort of tumor that's causing this reset in that hypothalamic thermostat. And, a number of other things as well. But I just wanted to mention this fever of unknown origin when talking about fever and when talking about the resetting of that hypothalamus. And here's just sort of a visual of some of those things that we talked about, but we don't necessarily need to get that specific. So that being said, is fever good? Well, yeah. I mean, obviously there are benefits of fever, and that's why your hypothalamus knows to sort of reset itself in these situations. The benefits of fever and the main sort of role of fever is that it does kill those microorganisms that sort of triggered it in the first place. It decreases certain levels of minerals in our body. It does fortunately promote lysosomal breakdown and autodestruction of those pathogens. It increases lymphocytic transformation and phagocyte motility, and it also can augment the antiviral interferon production and phagocytosis. And remember that we talked about last semester that antiviral interferon can be a really good thing. Interferon, remember, is the mechanism that once a cell has been infected by a virus, it cannot necessarily save itself from the virus, but it can send out messages to the other surrounding cells saying, hey, go save yourself, I've been attacked by a virus kind of thing, and it can actually protect other cells around it. So fever can actually augment that process, which is good. So those are some of the benefits of fever. However, we know that there are drawbacks of fever as well. We know that especially in the adult population, a fever over kind of bordering on like 104, 105 can be extremely dangerous. So anything like 105 and above, so 109, can be very serious and very dangerous, because one of the major drawbacks of fever at that high of a level is that it denatures the proteins in our body, and it can actually damage the cell plasma membranes in our body as well. So fever to a certain degree is good, and then fever beyond about 105 can be very pathogenic. So just kind of information there regarding fever. Okay. So there's a difference, though, between fever, because of some sort of infectious process going on, and the term hyperthermia, or obviously elevated temperature. So hyperthermia is not mediated by pyrogens, so it's not caused by, say, a bacteria. And really you don't see resetting of that hypothalamic set point on the thermostat either. So the temperature just kind of keeps rising, and there's never really a shut-off point or a period in which the body says, okay, that's high enough, that's good enough to take care of whatever microorganism is present, and there's no shut-off valve. So the body just the temperature keeps raising and raising and raising, which is extremely pathologic, because as I mentioned previously, a temperature above sort of 105 can cause nerve damage. and can produce sort of neurologic manifestations like seizures, convulsions. And anything above 109 is honestly not compatible with life. That's when you really start to see those proteins being denatured and that cell plasma membrane being damaged. So again, this is not due to some sort of pathogen. This is due to sort of like a heat exhaustion or a heat stroke sort of thing, in which the body temperature just keeps getting hotter and hotter and hotter, and the hypothalamus doesn't shut off. So forms of hyperthermia that we're going to talk about are heat cramps, heat exhaustion, and heat stroke. And again, a lot of the manifestations that we're going to be talking about with these three different forms of hyperthermia usually start happening around 105 degrees. So again, we're not really talking about anything below, bordering on that 105, 104 border there. So the first form is heat cramps. And heat cramps are sort of the lesser of the three forms of hyperthermia, or shall I say, less dangerous forms of hyperthermia. But what you see in terms of manifestations with heat cramps, as you see here on the screen, are severe spasmodic cramps both in the abdomen and the extremities. And what you see here with heat cramps too is that you see this prolonged sweating, and then you start worrying about profound sodium loss. Then you start having, neurologic symptoms because of the sodium that's lost as well. Usually who's most susceptible to this are people who are not necessarily accustomed to heat, and or they're out in the heat performing sort of strenuous work in very hot, warm climates. Manifestations that you'll see with heat cramps are fever, rapid pulse, increased blood pressure, oftentimes do accompany those cramps. So that's an example of the heat cramps. Now, a more severe sort of form of hyperthermia is heat exhaustion. And again, it kind of is what would sort of be like heat cramps elevated to the next level. So again, usually the result of prolonged high core body temperatures and or high environmental temperatures. So again, you're going to see prolonged vasodilation and profuse sweating. You can see a lot of sort of the hemodynamic changes that occur here on the screen with heat exhaustion, and then how that actually makes the patient feel. So what are some manifestations of heat exhaustion? You see that there on the screen as well. Okay, and then the worst sort of form and the sort of most worrisome in terms of life-sustaining ability is heat stroke. So this can potentially be lethal, and basically the reason that heat stroke would be lethal is because you have overstressed the thermoregulatory center in the brain. So as I mentioned, the brain cannot tolerate temperatures greater than sort of 105. And so what you'll start to see then is that you sort of see these cardiovascular and thermoregulatory centers actually stop working. Again, because of the issues with the cell plasma membranes and the denaturing of the proteins, they actually stop working with this high of temperatures in heat stroke. And again, it has to do, sort of who's most at risk is people who have done sort of prolonged physical exertion in a hot environment. In terms of clinical manifestations of heat stroke, you're going to see things, like I said, much more severe manifestations, much more severe than heat cramps and heat exhaustion. So you're going to see things like cerebral edema. And because of the cerebral edema, you'll start to see sort of neurologic symptoms like hallucinations. I had a patient one time in the ER come in a heat stroke who, we had sort of stripped off all of his clothes. We were packing his core in ice packs to try to get that core body temperature down. And so he was sort of lying there naked with, all the ice packs around his core, and so his feet were exposed. And he was sort of looking down at his toes, and he was telling me that he was hallucinating, but he was telling me how each one of his toes were different people, and they were all talking to each other. So, yeah, a little bit of a hallucination there, and again, due to that cerebral edema, which can be very serious and very life-threatening. So, along with the sort of degeneration of the central nervous system. You'll see swollen dendrites in the brain, and it can actually lead to sort of kidney trouble as well, and death. So interestingly, as I mentioned with this patient in the ER who was hallucinating with his toes, that you want to cool the core, but rapid peripheral cooling will cause peripheral vasoconstriction and can actually help limit core cooling. So you really want to pack cool these people in their armpits, in their groin, in their around their sort of carotid arteries kind of area, and try to very rapidly cool the blood, but in the core. This isn't something that they should have heat packs, or I'm sorry, ice packs out in their periphery, like their hands and feet and things like that. So again, heat stroke. So treatment is core cooling, not peripheral cooling. Again, talking about sort of the age spectrum, children are actually more susceptible to heat stroke because they actually produce more metabolic heat while they're exercising or through, some sort of prolonged exertion. They have a greater surface area to mass ratio, and they actually sweat less. They don't have the ability to sweat as profusely as adults do, therefore not allowing for that core body temperature to get cooled down. Okay, one more slide here on some type of hyperthermic situation, and that is something called malignant hyperthermia. So you might have heard of malignant hyperthermia. It's a complication of an inherited muscular disorder that oftentimes, and how you maybe have heard of it in the past, is that it often happens while someone is sort of in an OR, sort of operating room procedure. And the reason that you'll see or have these, sort of big, sort of serious complications while in the operating room. The reason that you see it most commonly, or you hear about it, I should say, most commonly, it happening in sort of like when someone's in surgery, is because oftentimes malignant hyperthermia is precipitated by inhaled anesthetics that they would use, in a surgical procedure to anesthetize someone, and or neuromuscular blocking agents. So there's a medicine called succinylcholine. You don't necessarily have to know how to spell it, but succinylcholine, which is a muscle relaxer and sort of neuromuscular blocking agent that they use in the OR to sort of open up and sort of relax their jaw and sort of their breathing pathway, so that it's more easily, they're more easily able to sort of intubate the patient and put down a breathing tube while they're in surgery. And it's a major trigger. Again, it's called succinylcholine, and we oftentimes would refer to it as sucks in the ER, because we would use it to intubate patients in the ER too, for like rapid sequent intubation in the ER. And that's actually one of the major triggers for malignant hyperthermia. So the way that I always think of it is that sucks. It can cause trouble. It can cause a lot of problems with people, on people who have this inherited muscular disorder. So basically, anyway, what happens is in malignant hyperthermia is that they have increased calcium release or decreased calcium uptake with muscle contraction. So the calcium sits there, and we know that when the calcium sits there, it allows for the binding of to the troponin tropomyosin site and allows for muscle contraction. And so you have what happens when the calcium is just sitting there on that site and allowing the muscle to contract. It causes this very serious, very life-threatening, sustained muscle contraction in all muscles of the body. So not only in their, legs and arms, but also in their diaphragm and basically every muscle in their body. So we know that an increased muscle contraction will obviously increase oxygen consumption to those muscles. And then we know once that starts to happen and you sort of deplete your oxygen supply, you start to go into sort of anaerobic, cellular metabolism, cellular respiration, and you get a buildup of lactic acid production, which can cause someone, as we talked about in the fall semester, can put someone into pretty extreme metabolic acidosis, which is life-threatening. So malignant hyperthermia is life-threatening, and symptoms include absent reflexes, fixed pupils, trouble breathing or not breathing, and a flat EKG. So it obviously affects the contractility of their heart muscle as well. And interestingly, it's called malignant hyperthermia, but actually the actual hyperthermia, or the elevation in their body temperature, is actually one of the later signs. So if you're in the OR, you're an OR nurse, and first of all, you always ask, is there anyone in your family that's ever had, trouble in the OR sort of thing? And that's why they ask that question, is they're getting at this malignant hyperthermia inherited risk. But once you're in the OR, so like I said, once you're the nurse in the OR and you see an elevated temperature in someone, it's actually a late sign and is pretty hard to reverse at that point. So you need to look at other things like you see here in some of the other symptoms. It is reversible. There's a medication, again, you don't have to know this, but it's called dantrolene, that actually is sort of the reversal agent of malignant hyperthermia, but it needs to be given pretty early on in this hyperthermic process, not once the patient is, has a very elevated body temperature. Anyway, that's malignant hyperthermia. And again, that's one of the reasons why when you're going in for surgery or a patient's going in for surgery, they ask, have you ever had any trouble with any sort of anesthetic agents, or has anybody in your family, because it is inherited, ever had any trouble with anesthetics in the OR? Okay, so that was our last slide on hyperthermia. Now let's talk on just these next 4 slides about hypothermia, so the opposite. This is where a body temperature is less than 95 degrees Fahrenheit. And what kind of trouble, what kind of problems does hypothermia cause? Well, it causes central nervous system and respiratory depression. It obviously causes pretty profound vasoconstriction, alterations in microcirculation, and it honestly makes the blood thicker and sort of sludges it up. So you've got issues with circulation, with coagulation, and sort of the clotting and clumping together of the blood. And therefore, if you've got these clots and this clumping of the blood, then you're not going to be able to move the blood through, either because of blockages or just because the blood's honestly running slower. You have changes, ischemic changes and ischemic tissue damage because you're not getting that blood supply and that oxygen supply to tissue. And then you can also, honestly, with a temperature less than 95 degrees Fahrenheit, actually see ice crystals form inside the cells and causing the cells obviously to rupture and to die. So hypothermia is just as dangerous as hyperthermia. Tissue hypothermia, you can see what sort of occurs here, slows the rate of cellular metabolism, increases the blood viscosity, as I mentioned, and facilitates blood coagulation. So we sort of mentioned that already. And there really is 2 types of hypothermia. So accidental hypothermia, like the kind you would see if someone falls through the ice, so to speak, on a frozen over lake and they fall through into the ice cold water. Or in my experience in the ER, people just having a prolonged exposure to cold, like the homeless that sleep outside on a, -3 night sort of thing in the winter. Saw a lot of that accompanied with like frostbite and that type of thing. So that's sort of accidental hypothermia. And then you have actually therapeutic hypothermia. And the reason that they use therapeutically hypothermia in a lot of sort of clinical situations is that they use the hypothermia as sort of cooling down the body temperature, slowing down their metabolism to preserve ischemic tissue damage. Sometimes they'll do it during surgery. They'll actually cool off and sort of decrease a patient's core body temperature during surgery. If they're trying to sort of reimplant a limb that maybe has been accidentally amputated in some sort of traumatic injury, head injuries, and people who have survived cardiac arrest, who have survived a code, so to speak, because it, again, slows down the metabolism, slows down the bodily needs, the cellular needs, and preserves some of that ischemic tissue in some of those areas. Now you do have to be careful and obviously not lower the body temperature too low, so there's very close monitoring of that body temperature. And the reason that you have to be so careful is because therapeutic hypothermia can cause issues as well. So it can cause ventricular fibrillation, which is a fatal arrhythmia, and then obviously cardiac arrest completely. So it has its moments where it's good, it has its uses, but you have to be very cautious and careful and monitor closely. And then last but not least, so trauma and temperature change. And I don't necessarily see this so much in the ER because we see them for such a short period of time after trauma, but this is something that you'll certainly know and will certainly be familiar with if you ever work like in an ICU setting, like in a trauma ICU. So central nervous system trauma actually can lead to something called central fever. And it's caused by inflammation, increased intracranial pressure, and intracranial bleeding are some of the things, some of the reasons why you might see this sort of pathologic hyperthermia in someone. Again, it does not mean that the person actually has a pathogen on board. So there's no pyrogen causing a fever. But you can certainly see it sort of because the increased metabolic demands that an injury has on a person and their temperature. So things like accidental injuries, hemorrhagic shock, major surgeries, and thermal burns can actually increase and change someone's temperature because of sort of bodily trauma. And I do apologize. This is kind of out of order. It should be with the hyperthermic, not the hypothermic slides. But again, to be clear, trauma and temperature changes is not due to some sort of infectious agent, so it's non-infectious. A central fever does not include some of the other things that you see with fevers, like sweating, and it's very resistant to antipyretics. So it's antipyretics would be like a Tylenol and Advil. Sort of, or Tylenol or Motrin, ibuprofen, that you'd give obviously to try to decrease someone's body temperature, to decrease hyperthermia. Unfortunately, because this isn't due to sort of the same mechanisms that other hyperthermic situations are due to, that antipyretics don't really work, unfortunately. And the severity and the type of alteration that this causes varies, obviously, with the severity and the body systems that are affected. So just wanted to sort of briefly mention that, and I do apologize. That should sort of be with the hyperthermic conditions, not the hypothermic conditions. Okay, and that is it. We will move on Thursday to talking about more specific clinical sort of conditions, alterations in cognitive systems, and cerebral hemodynamics. So I will see you then.